We are Sisu Global Health, the medical device company for emerging markets. And today we're excited to announce a new webinar series called Saving Lives with Autotransfusion, Lessons from the Field. A Sisu Global webinar series where clinicians speak about their experience using Hemafuse in surgery and other global health issues. Hemafuse is a medical device that operates on the idea your own blood is better than someone else's. For cases of internal bleeding, Hemafuse can capture blood from that internal bleeding, filter it, and give it back to the same patient in the same surgery so they don't need someone else's blood. Today, we're excited to introduce you to Dr. Gwer. He's a Kenyan medical doctor specialized in obstetrics and gynecology. He's a member of the faculty at Maseno University, where he chairs the Department of Obstetrics and Gynecology in the School of Medicine. He's also an honorary staff member at Jaramogi, Oginga, Odinga Teaching and Referral Hospital. Dr. Stephen Gwer is an associate research scientist, Nyanza Reproductive Health Society. He's an extremely experienced researcher, and we're honored to have him with us here today. Today's session is being hosted by Dr. Asma Awadh. She's a senior training coordinator for Sisu Global Health, and she's a very experienced clinician herself. She's seen many surgeries where Hemafuse has been used and will be able to guide us through with her clinical, research, and Ministry of Health background in this series discussion. Today's presentation is on ruptured ectopic pregnancy and autotransfusion using the Hemafuse, a case presentation. It will be presented by Dr. Stephen Gwer and by his colleagues, Dr. Stephen Juma and Dr. Edward Owila. They're all researchers at the Jaramogi Oginga Odinga Teaching and Referral Hospital. Today, we will be talking about a patient at JOOTRH. We'll call her EL. She's 25 years old and she's a farmer from Oginga. She's married and...
Interestingly, from her two pregnancies, there was no living child, as the firstborn died at 2 years due to condition related to severe anemia, and the secondborn similarly succumbed at 4 months. And she had a lot of hopes in this pregnancy. Yeah, so she arrived at a hospital on the 19th of February in the night. Complaint was that she was having vaginal bleeding, and this bleeding was heavy and in clots. She was also having abdominal pains, and she was having generalized weakness with easy fatigability and awareness of heartbeat. She had had similar complaints a month prior and was treated in a peripheral health facility as an outpatient and sent home on oral medication. However, she noted that this time the pain was so intense, she described it as gripping, and that is what made her come to a bigger hospital. And the weakness was so much that it precluded any of her usual activities. Next slide. At casualty, she was found to have she was largely normotensive, but interestingly, her pulse at 112 beats per minute was higher than her systolic blood pressure, which already set alarm bells. She was noted to be markedly pale. Her abdomen was swollen, but there was no obvious palpable mass. A pelvic exam revealed active bleeding from the external lobes, though clots were not evident at that time. She was so weak, she could not walk without assistance and was being moved around by a wheelchair. Next slide. The clinician on duty recommended an ultrasound. And in our hospital, the ultrasound reports are handwritten, especially at night. And these were the findings. Ominously, the ultrasonographer reported an irregular right iliac fossa mass and also reported marked ascites. I think what our sonographer should have reported was that there was fluid in the peritoneal cavity. and made a recommendation that an abdominal CT should be done. This was the only test that was done at casualty that night, and it is from this the medical officer formed his impression. Next slide. Now, interestingly, his initial impression at casualty was based on the ultrasound finding of an empty uterus and the period of amenorrhea. So the clinician at casualty made a diagnosis of complete miscarriage and entertained differentials of abnormal uterine bleeding and a hemorrhagic cyst. None of his differentials included an ectopic pregnancy. He requested the patient to be given tranexamic acid, paracetamol, and admitted for gynecological review, and requested some lab work. Curiously, the doctor in casualty did not find the ultrasound done initially at night to be very revelatory and requested for another one to be repeated the next day. Next slide. Between 19th February and 23rd February, this lady stayed in the gynecological ward, and it is not clear what happened in between that time. All that we noted was that on the 22nd of February, a pregnancy test was ordered and it was positive, which is not surprising whether this was a miscarriage or an ectopic. At that time, during the ward round, an examination also revealed shifting dullness in keeping with the intraperitoneal fluid. She had just been receiving analgesics and tranexamic acid. The CT, abdominopelvic CT scan that was contemplated initially, that thought was revisited, but it was never done. Next slide. Now, on the 23rd of February, around 4 days after admission, a consultant reviewed the patient in the ward, performed a paracentesis, which is what should have been done at the very beginning, and it was positive. He made a diagnosis of ruptured ectopic and recommended laparotomy. Next slide. The patient was taken to theater, and the finding was a right fimbrial ectopic. The left fallopian tube was healthy. There was found a hemoperitoneum of approximately 2 liters. Right salpingectomy was done. 2.5 pints of blood were collected with the Hemafuse device and transfused to the patient. Next slide. Now, for this patient, this was amongst the first time Hemafuse device was going to be used by the people who were in theater on that day. So I was called in, and we exercised what we had always practiced on the humanistic models. We used the device to gently and carefully collect 2.5 pints of blood, which eventually was given to the patient. Next slide. Next slide. Now, as you can see, while in the hospital, the patient had several hemograms done to look at her blood level. And I have put here the picture of the first and the last hemogram that was done. At admission, her hemoglobin level was 5.51 grams per deciliters, while at the time of discharge, it was 9.92 grams per deciliter. Yet, she did not receive any other transfusion apart from higher than her pre-transfusion HB. Although a pint of blood had been availed in theatre, it was not used because we'd already harvested adequate blood intraoperatively. Next slide. So on the 26th of February, being her third postoperative day, she was found to be well. Her incision site was healing properly. She was discharged home and was scheduled to come back for review in the clinic. However, she did not turn up for her appointment. And we tried to call her on 2 occasions, but the phone number she had given us ended up going to a different person. Next slide. We're just going to have a brief discussion. We know that autologous blood transfusion or autotransfusion is a procedure in which a patient receives her own blood. It is taken out either at time of surgery or before and returned to her at a later time. It is considered the safest blood available as it avoids several transfusion reactions and transmission of illnesses. We realized that in the early 80s, as the HIV virus became more well known, there was a reawakening on autotransfusion. And it coincided with a lot of scientific and technological advances to increase autotransfusion. And physicians and scientists have modified several surgical procedures and devices to make autotransfusion feasible. Next slide. The Kenyan guidelines on appropriate use of blood and blood products provides for the provision of autologous blood transfusion. This has been in the Kenyan system for a long time. However, many hospitals have lacked validated tools for conducting autotransfusion, and as a practice, autotransfusion has been dying slowly by slowly. Yet blood safety and blood products are becoming scarce and scarce over time. Next slide. There are several types of autotransfusion. And in our case, we are discussing intraoperative autotransfusion, where pooled blood is collected during surgery. It could be filtered and given back during the same procedure. This is the most common type of autotransfusion, and it serves people well during emergency surgery, especially if there is massive internal hemorrhage. It can be recovered and given back to the patient. We realized that our patient had a tentative diagnosis of ascites. Yet, what we knew was that this was fluid, most probably blood, indicating that there had been massive bleeding. Next slide. The other type of autotransfusion would be cell separation. But the cell separation machine is available only in 2 or 3 hospitals in the whole country. And therefore, it is hardly ever used in setup, and most clinicians are not versed with its use. And even in the hospitals where it is available, It is reserved for specialized procedures like heart surgery and vascular surgery. Whole blood autotransfusion has been practiced using rudimentary means, but the Hemafuse device now provides an opportunity to use a validated tool for autotransfusion. Next slide. There are several benefits of autotransfusion. For one, we know it reduces the use of volume expanders. It reduces the risk of getting infective organisms. Red blood cell storage, the red cells that have been stayed in a blood bank in the blood bank for a longer period may not be as good in transferring oxygen as blood that has acutely pooled in the peritoneal cavity. And also the other transfusion reactions and errors, clerical errors at the laboratory are avoided. Next slide. It becomes therefore possible to find indications for whole blood autotransfusion. Any of the circumstances where you are likely to encounter a massive hemoperitoneum, as in our case, the ruptured ectopic pregnancy, becomes a possibility of doing autotransfusion. Next slide. There are several contraindications, and therefore one has to, in choosing the patient who will undergo autotransfusion, one has to look out for them. In our case, the most one of the likely risks will be sickle cell anemia. However, it would be very rare for a woman to reach adulthood and not know that she has sickle cell. Our patient did not have any contraindication to autotransfusion because she was bleeding from an ectopic. There was no perforated viscous noted during surgery. It was just fresh peritoneal blood. Next slide. So autotransfusion for ruptured ectopic pregnancy is not recent. As you can see from this series of studies, Medline search that started as early as 1966 to 2002 revealed several papers that showed where autotransfusion has been done, and some of them in developing countries. And as is written in the abstract, they said that the procedure was conducted manually in an infusion bottle without the need of filtering and transfuse it back to the patient. I concur with that conclusion that autotransfusion is therefore useful in the management of ruptured ectopic. Next slide. Moreover, as we can see, the papers that were looked at had several papers from Kenya, some from Liberia, Uganda, Tanzania, and some from the developed world. And this indicates that autotransfusion used to happen in Kenya even in the 70s. The earliest paper from Kenya was in 1972. The oldest paper was 1970 in Jamaica. Blood retrieval was simple. There were no sophisticated equipment that were used then. There was no need for electricity or storage facilities. The blood will be scooped, sifted through a piece of gauze, put in an infusion bottle, and returned back and retransfused back to the patient. I think with those few slides, we can now discuss the case. I will be glad to respond to any questions. And my colleagues, Dr. Juma and Willa could also chip in case I've forgotten something.
Thank you, Dr. Steve Gwer, for that, for sharing your experience. And the team, Dr. Edward Owila and Dr. Steve Juman, thank you very much for sharing the experience that you have had with the use of Hemafuse. It's always best when we learn from our fellow clinicians on regards of use of equipment so that we know if there are any gaps we can always discuss. I'm sure there are members from the participants who will also want to ask some of the questions to understand or to actually answer their questions in the gaps that they've experienced when they are using the device. But before I open the session for question and answer to the audience, I would like to ask some few questions to Dr. Steve and your team, Dr. Edward and Dr. Steve. So if I may start, the first question is, what was the clinical signs that patient presented with that made you consider the use of Hemafuse in this particular case?
Well, thank you, Asma. In this particular patient, you realize that she presented with marked pallor. She was markedly pale. And two, we had an ultrasound report that indicated there was fluid inside the peritoneal cavity, and which made us know that, of course, there is harvestable blood. And we were already aware she's pregnant, and it was therefore likely to be an ectopic, which is one of the indications for where autotransfusion is feasible.
Thank you, Dr. for that. And if I might ask another question is, what risk did you look for or did you evaluate before using Hemafuse in this particular procedure? Was there any risk that you are worried about in regards, because I saw in your presentation you talk about the indication and contraindication. So for this particular procedure, were there any risks that you are looking for or you are evaluating before making that decision to use the Hemafuse device for the procedure?
Well, for this particular patient, she was low risk because ordinarily we would be worried if there was a perforated viscous, like maybe the intestine, or maybe if there was urine in the blood, or maybe if there was some indication for sepsis. But we looked at a full hemogram, which was not in keeping with any infection. And when we opened and we saw the blood, it was largely clean, and the gut was intact. And we knew she did not have a malignancy, and we knew she did not have sickle cell disease. So everything was in favor of us doing the autotransfusion.
Thank you, Dr. Now, if I may ask Dr. Steve Juma, did the patient recovery proceed differently than expected, or it was what we were expecting?
This patient, good evening to all, sorry. This patient after the operation, interestingly, by the second day, the signs of anemia had almost gone. She was stable. She no longer had the palpitation she had. Her pulse was better. And as you see, her recovery process went well. So we had no issues concerning her recovery. And the good thing, we were able to avert her anemia situation almost immediately.
So the follow-up was a bit faster than usual.
Yeah, while in the ward, we were able to monitor her progress closely. Remember, Dr. Gwer said we did serial complete blood counts to check how the HP was behaving. And even by discharge, by day 3, she was ready to go home.
Thank you, Dr. Now, if I may ask, lastly, Dr. Gwer and team, so how has the autotransfusion in using device like Hemafuse affected the hospital or the patient that you're having? Is there any effect that you have noticed in the use of autotransfusion or autologous transfusion?
Asma, I will first point out that when we do the autotransfusion as a surgical team, we are happy with ourselves. When the procedure goes on well like that, the patient is satisfied and the surgeons are also happy. And we know we save blood that would otherwise be used to save another patient. However, I cannot say that we have had so many uses for us to have a hospital impact. Largely, we've used them for ectopics, and we are trying to entice our surgical team to also try and use them for other indications like ruptured spleen, which is pretty common in our area. So we, as we use it more and more, I am sure we will demonstrate impact and have more lessons for everyone.
Fantastic. Thank you so much, Dr. Gwer. Hello, everyone. This is Tim Goodwin with Sisu Global Health. It appears Dr. Asma's screen may have frozen a little bit on her. So I anticipate her back any second now. Dr. Asma, are you back with us?
I am back, actually.
Fantastic.
Yes.
Fantastic.
Apology on that. Thank you, Dr. Gwer and Dr. Juma and Dr. Wheeler for sharing your experience. We have learned a lot from your experience in the use of Hemafuse. I would like to open the discussion to the rest of the participants. And before I open the discussion, I'd like to introduce Tim Goodman. So Tim is also at the training consultant with the Sisu Global Health, who will also join the panel now to answer questions from the audience, together with Dr. Gwer and the team from Jaramogi Odinga Hospital. So we'll start. There's a function on the side where you can raise your your hand if you want to ask a question. Kindly use that so that we can pick and have people raise their hands if they need to ask any question. So I don't know if people can see there's raised hand on the side where you can click on it and I can pick you easily from the participant list and you can ask your question. I'd like to invite Dr. Steve Frank to ask.
Hi, Dr. Asma. Thank you.
Hi,
this is Steve Frank. What an amazing story and an incredible save that you made for this patient. I'm really, really excited about this. My question is pretty simple, and that is, how can the device work if the blood has already clotted or partially clotted? Is it possible to salvage clotted blood? And so how fast do you have to get at the blood to salvage it?
So, Dr. Gwer, you can.
That's a very good question. Most of the time after blood has pooled in the peritoneal cavity, as we do during paracentesis, it remains unclotted. It will not clot even if you took it out with a syringe. During surgery, you will find there will be clumps of clots in the blood, and you can avoid this. Recall you will be suctioning this and transferring it to a blood bag that is saturated and will further prevent clots. So all you'd have to do is to avoid the clots that have already formed in the peritoneal cavity and suction the unclotted blood.
Excellent. Thank you for that explanation. I know Dr. Waters in Pittsburgh says that you can salvage red blood cells from clotted blood. You might not get as many red cells as you do from unclotted blood, but he says that you can still salvage red cells. So that's promising. Thank you.
Thank you.
Thank you, Dr. Gwer, and thank you, Steve, for the question. Now, there is another question that has been raised in the chat that I'll actually post for you, Dr. Gwer and the team. In your facility, with the use of Hemafuse, who handles the device? Is it the anesthetist, the perfusionist, or a trained nurse?
Well, let me let Dr. Juma respond.
Okay, concerning that question, so far, we've had a team of one, the surgeon who is the lead surgeon. Anesthetist's role is to help in transfusing the patient once bleeding is contained from the ruptured site. But who handles the device is another resident doctor or registrar. So we have a team with 2 registrars or resident doctors operating on this particular patient. And the role of the other registrar is to help handle the device. Thank you.
Thanks, Dr. for that answer. I'm seeing there's somebody who has raised their hands from the participant, Samuel Mosieri. Samuel, can you ask your question before I ask the other question from the chat?
Yeah, hello, good afternoon to everyone.
Good afternoon.
Please, I would like to know if Dr. Juma or Dr. Steve can give us a little detail about some setbacks with the use of the Hemafuse device. Since they have used it for some time, if they can tell us some experience that some setbacks of the device that we, those who are yet to use, along the line we might be facing with the device, so that when the time comes, we'll know what to do.
Oh, thank you for the question. From our initial experience, we had challenges with ensuring that the device is airtight and that there is no leakage which will affect during the aspiration of blood. Also, while aspirating the blood, there has to be a level of patience. When you pull the plunger fast and you expect the blood to follow into the barrel, it doesn't work that way. You have to create some vacuum, be patient, give it a bit of time, and the blood will flow. You have to sustainably have pressure in the barrel, or else it might be an issue. Also, during now collection of the blood, Initially, we used to not turn the device, and we could end up with pouring out the blood which was already collected, going the wrong direction. So with the time, we've perfected this, and we are even able to collect the residual blood which some groups can have remaining in the barrel by just turning the device upside down, and by gravity and a bit of pushing the plunger back, we are able to collect almost all our blood. Thank you.
Just to add one point, we think this is an innovative device to use, but we have to be careful on which patient to select for using this device, because otherwise you might waste it. One thing is that the device can be sterilized with an autoclave. However, the autoclaving temperature for this device is sometimes different from the autoclaving temperature of some of the autoclaves. So one drawback is that if you are to have it, either you should have an autoclave machine for which you can set the temperature, or have two autoclave machines. But otherwise, we think this is an excellent device for the well-selected patients.
Thank you, Dr. Juma. Thank you, Dr. Steve Gwer, for that answer. Now, I have another question that is in the chat. Dr. Gwer, in some advanced cases of rapid ectopic pregnancy, such as corneal ruptures, placenta tissue can be seen in the abdomen. Is it safe to salvage blood that contains placenta tissue?
Thank you. Thank you for the question. Most of the time, ruptured ectopic pregnancies would be below 12 weeks gestation. And though it will not appear safe to give blood where there has been placental tissue, we know that in the rupture of ectopic, some of the blood definitely must be having trophoblastic tissue. The case series that I presented had a large number of patients, none of whom had any reaction from having this blood retransfused back to them. But understandably, if you think the pregnancy is large, like you are dealing with a mid-trimester pregnancy, whereupon in addition to placental tissue, you could be having amniotic fluid, then it might not be safe. But for the humdrum common ectopic pregnancy that we see in first trimester, there are several case series and the systematic review that I shared that have found it to be safe.
Thank you, Dr. for that answer. Kindly feel free to raise your hands in case you have any question, but there is a question that I will direct this to Tim Goodman. So Tim, there's a question here that is asking, what is the size of the filter in microns?
Yes, thank you, Dr. Asma, so much. The size of the filter in microns is 170 microns, more than adequate to trap clots in any contaminants or particulates that may be present. And I also want to note that as well as this blood that is collected with hemafuse is then transfused back to the patient via a infusion set that will have that 20 to 30 micron microemboli blood filter as well. There's the 170 micron filter in the hemafuse itself, and then the blood is transfused back with the standard infusion set that comes with that microemboli blood filter as well.
And just to add, the filter has a one-way valve that actually stops backflow blood, which stop any contamination of blood moving from one compartment to another one. Now, I'm not seeing any other question on the chat room. Anyone with any question or any clarification, or even anything you want to share? So I'm seeing 2 hands that have been raised. So I will go to Kariko.
Thank you very much. I think there were questions that were posted in the chat that I'm sure probably you are not seeing. One of them was the rate of recovery of the patient who received autotransfusion compared with those who received allogenic transfusion from the hospital, if he can throw some light on that one as well. And then in addition to the cost implication and the length of hospital stay as well.
So Dr. Gwer, if you can cover for us, what are the recovery for patients who have received autotransfusion vis-a-vis the ones who got the allogenic blood, and the hospital stay with the patients who have been given autologous blood vis-a-vis the allogenic blood. And then Tim, can you answer for us the issue of the pricing?
Thank you for the question. Well, in our hospital, we have noticed that sometimes blood is not available. So the patients who do not receive, the patients who do not get autotransfused, some of them do get allogenic blood transfusion, and some do not get transfused at all. For those who get adequate amount of allogenic blood transfusion, their recovery is similar to those who have been autotransfused. But for those who end up not getting adequate blood from the blood bank, their recovery is not as good as those who've been autotransfused or those who've been have had allogenic blood transfusion. And sometimes they get discharged while still having some degree of anemia. But as we have noticed, the autotransfused blood is just like allogenic. Once you get it, your HB is better than it was pre-transfusion.
Thank you, Dr. Gwer. I hope that has been cleared. Tim, can we hear from your side in regards to pricing of the device?
Yes, absolutely. So in terms of pricing, that will depend on a bunch of factors. Sisu Global Health is a private company that is the inventor and manufacturer of Hemafuse, but we work with local distributors in the countries in which we sell Hemafuse. So in terms of a price to give you, I don't have an answer, as that depends from country to country basis. What I can tell you is we have seen significant cost savings in the fact that Hemafuse does whole blood autotransfusion, and you can salvage multiple units with one Hemafuse system. So up to 3 units for one patient. And then adding on to that, some of the effects that Dr. Gwer has mentioned and that we see from autotransfusion being done in general, such as the lower rate of the lower length of hospital stay and quicker recovery, and lower risk of infection and lower rates of post-surgical complications and infections. Those are some of the things that create the cost savings from the Hemafuse device.
Thank you, Tim, for that elaborate answer. Now, I have 2 last questions before we wind up the session. I can see time is running out. So there's somebody who has raised their hand, Samuel Musieri, and then we have one question in the chat.
Okay, please, I would like to ask, when you're using the Hemafuse device and you start experiencing high resistance between the barrel and the ring, what would be the best solution to do?
Thank you for your question, Samuel. What I have, there are two issues I've encountered while using the Hemafuse device that can lead to the resistance. One is you will meet considerable resistance if you try to if you try to fill in the barrel very quickly. But if you move very slowly, the resistance would be reduced. On the other occasion where we encountered resistance was when we realized that the device had been autoclaved with a different temperature, and that could have affected the plastic itself. But generally, if you take time, you don't apply too much, you don't try and fill the barrel quickly, then you will realize that you are not encountering a lot of resistance. Please unmute Asma, we can't hear you.
Thank you. Sorry for that. Thank you very much, Dr. Gwer, and also for reminding me that I'm still muted. So I want to ask a question from the chat room. Before we go to the question, we have another person who has raised hand. So a question from Frederick. In the use of the device in sepsis, and that is one of the relative contraindications, can it be used in conjunction with appropriate antibiotic therapy, since the fear of reinfection can also be there with the use of the allogenic blood? So can we use this? Can we salvage the blood, then put our patient on antibiotic where the sepsis is concerned?
Well, in this situation, sepsis is a relative contraindication. And I know each hospital would, having acquired the Hemafuse device, would also go on further to create their own protocols of use. It will require one to be very circumspect in picking who will get transfused. So, for example, if there is overt peritonitis and you are transfusing blood from this, you will be generally worsening the condition. So in our facility, we do not we do not transfuse. We do not do autotransfusion if there is sepsis. However, if in your opinion, this is the only life-saving procedure, there is no allogenic blood, the patient has had massive hemorrhage, this blood is there and this is the only one you have, maybe then weighing your risks versus benefits, you may consider that transfusion. This is usually an individual call on table.
Answer. Now, I will give a final question to Kariku, but remember, there is an information that is posted on the chat. If you have any further question or you want something to be clear, please feel free to send an email to team.goodwin@sisuglobalhealth.com or to information@sisuglobalhealth.com. But let's have Kariku as our final question, and then we wind up we wrap.
Thank you very much, Madam, for the opportunity. I would like to go back to the rate of recovery of patients who receive autotransfusion and those who receive allogenic blood. Doctor said that they do very well, the same thing. I want to find out if they've had time to study. For example, in allogenic blood transfusion, we are doing pre-medication. We are monitoring for transfusion reactions, intra-transfusion and post-transfusion. I don't know whether they do the same thing for those who receive autotransfusion. And once there could be immunosuppression with the use of allogeneic blood transfusion, definitely those individuals are going to stay longer, and attention given to them is going to be more than those who receive autotransfusion. So having said that, they do very well, the same rates, and they stay at the hospital at the same time, I want to know if it's researched into that already.
Thank you for your question once again. Let me point out that we monitor in our setup, we monitor both patients who receive autotransfusion and those also who receive allogeneic blood transfusion. Let me also say that transfusion reactions in our setup are rare. Most of our patients who receive allogeneic blood transfusion hardly ever develop features of transfusion reaction. And most of the time, notwithstanding that the issues you raised are logical and point towards the need for those who receive allogeneic transfusion to have a longer hospital stay or a more tempestuous postoperative period, what I have noticed, though we've not studied it scientifically as you have asked us to do, what we have noticed is the patients who receive adequate transfusion, be it auto-transfused or allogeneic cross-matched blood, they tend to have a similar outcome. Therefore, it seems autotransfusion and is non-inferior to allogeneic blood in respect to postoperative recovery. Its benefits may be there, but when we are discussing postoperative recovery in our setup, they seem to do just as well. Our problem usually is in those who do not get enough blood. So for example, only 1 pint of blood was available where they could have used 2 or 3 and they remain anemic and sometimes therefore stay longer. So these people will be staying longer in the hospital because they are waiting for blood to be transfused. But as regards fever and so on, most of them, they're just the same.
And Dr. Gwer, could you just expand upon that point you just made where some patients there's not enough blood available and some patients can't get all they need? I know you've only been using Hemafuse for a short amount of time, but have you seen that with the units you're able to salvage with Hemafuse, more units being available so patients are able to get more donor blood in total?
What usually happens in our setup, blood is not as much as we would like it to be. It will be unusual for an individual patient to receive after surgery for ectopic to receive more than 2 pints. And yet sometimes the loss they will have had is one that requires more transfusion than they receive. So they end up staying in the hospital longer, not because they have received allogeneic blood transfusion, therefore having adverse effects. It's only because they need more blood. There are some who come who are rhesus negative or who have a rare blood type and who do not get blood at all, and therefore end up staying longer in the hospital just waiting to recover from their anemia as blood is being sought further.
Great. Thank you.
Thank you, Dr. Gwer, for that elaborate answer. And I would like to invite Tim Goodman to actually now wrap up the session. And Tim, welcome.
Thank you so much, Dr. Asma. And Doctor, I'd just like to start by extending a huge thank you to everyone who has shown up. for series number 1 in Saving Lives with Autotransfusion Lessons from the Field. We do intend to have many more in this series, and the next speakers will be blasted out in much the same way as you receive notification about this session here. We anticipate having a presenter from Ghana for our next series. I'd also like to extend a huge thank you to Dr. Stephen Gwer, Dr. Awila, and Dr. Juma for presenting this case for us, and for all of you who asked questions as well.
From Sisu Global, we want to say thank you for joining us today at our new webinar series, Saving Lives at Autotransfusion, Lessons from the Field. Thank you for listening to our clinicians as they spoke about their experience using Hemafuse. And if you're interested in hearing more from Sisu Global and seeing other webinar series, please follow us on social media, Twitter, LinkedIn, or Facebook, and you'll be able to hear about future events, future training sessions, and future webinar.